Now let's start about the glomerular diseases. So glomerular diseases, we basically classified them into nephrotic or nephritic syndromic presentation. So the clinical presentation of both these syndromes are going to be different. So when a patient presents with a nephrotic syndrome, the patient is going to have massive proteinuria, especially it is going to be more than 3.5 gram per day. So this will be the clue given in the question. So whenever they mention proteinuria more than 3.5 gram per day, then they are suggesting a nephrotic syndromic presentation. So when lots of protein are being lost, what will happen? When protein is not there, the oncotic pressure cannot be maintained, and that will result in a severe edema. So the patient will have severe edema. Other than that, the lipid binding proteins, which are also proteins, are also going to be lost. So that will result in hyperlipidemia. So hyperlipidemia is there, that will result in lipiduria and presence of lipid casts in the urine. So there will be lipid casts in nephrotic syndrome. So coming to nephritic syndrome, here the patients will have a proteinuria which is less than that of the nephrotic range. That is less than 3.5 gram per day of proteinuria will be there in nephritic syndrome. Along with that, they'll classically have hematuria and hypertension. So hematuria, oliguria, and then hypertension along with presence of RBC casts are the classical features of a nephritic syndrome. So there are various patterns under this nephritic and nephrotic syndrome. So under each of these patterns, many of the diseases can present with the different patterns of nephritic or nephrotic syndrome. So let's start with nephritic syndromes first. The first one will be that of a acute proliferative glomerular nephritis. So as the name suggests, there is going to be some kind of proliferation happening in the glomerulus. This proliferative component can be of the cells included in the glomerulus, basically the mesangial cells, the capillaries, or some infiltrating WBCs in the glomerulus. So this type of glomerular nephritis is going to be the most common kind of nephritic syndrome seen in children. So the best example of this acute proliferative glomerular nephritis will be a post-streptococcal glomerular nephritis, which is called as PSGN. So already we had seen in RHD that RHD was caused by group A beta hemolytic streptococcus. The same group A beta hemolytic streptococcus is only going to cause this PSGN, but here the episode will happen post a pharyngitis or a post skin condition which is caused by the streptococcus called as impetigo. So 1 to 4 weeks after this pharyngitis or impetigo, the patient is going to present with a hematuria and a kidney disease. So that is when you suspect a PSGN in a kid. And usually the age of the kid will be 6 to 10 years old. But the most important thing here will be the strain which causes this PSGN. The streptococcus strain, which is 12, 4 and 1. So these three strains are responsible for causing glomerular nephritis, while strains 1, 3, 5, 6 and 18 was responsible for causing RHD. So remember this. And also, this is going to be an immune complex mediated disease. So whenever there is going to be immune complex mediated disease, it is a type 3 kind of hypersensitivity, right? So this PSGN is also an example of type 3 kind of hypersensitivity. So clinically, all the features of nephritic syndrome will be present, and classically we call the hematuria in these patients as cola colored urine, because the urine, after giving out RBCs in the urine, these RBCs are going to be lysed and they will acquire a brown color. So it looks like Coca-Cola, and that is why it is called as cola colored urine. Since it is an immune complex mediated disorder, so the complements are being used up here. So when you measure the serum complements, they are going to be reduced, especially C3, which is the common pathway. So C3 complement will be reduced. And in order to prove the streptococcal infection, we can do antibody titers. So you can either use an anti-streptolysin O antibody titer or anti-DNase B antibody titer. So anti-DNase antibody titer is much more sensitive and specific than that of a anti-streptolysin O antibody titer. Usually this PSGN presents in children only, but it can even affect adults. So in children, it is self-resolving. So more than 90% of the children resolve with just supportive therapy. While in adults, only 60% will be resolving, and rest of them can proceed on to end-stage renal disease or even RPGN, which is rapidly progressive glomerular nephritis. So what are the features of this PSGN? So grossly, if you see, there will be a flea-bitten kidney. This flea-bitten kidney appearance is nothing but this dark spots are present in the kidney, right? So these are nothing but pinpoint hemorrhages seen on the surface of the kidney. So since it's a proliferative glomerulonephritis, the kidney is going to be enlarged and it will also have this pinpoint hemorrhages. So this flea-bitten kidney is not specific for PSGN. You can also see it in other conditions like RPGN, then infective endocarditis, and also in malignant hypertension. So all of these conditions are going to have this flea-bitten kidney appearance. So on a light microscopic image, the PSGN, since it is a proliferative glomerulonephritis, the glomerulus is going to be quite proliferative and enlarged. So this entire glomerulus is completely filled up with cells, right? So these cells are actually nothing but the mesangial cells. So the in between you are seeing pink material. No, see that these are nothing but the mesangial cells, and also you can see these kind of cells. So which are lining the capillary lumen. So these are the capillary endothelial cells which are also proliferating. Other than that, if you see, you can also see the presence of these neutrophils. So neutrophils are present in the capillary lumen. So this kind of WBC infiltration will also be there in an acute proliferative glomerulonephritis, since it is a bacterial infection which is triggering that. So if you see any immune complex mediated disorder on immunofluorescence, the classical feature of any immune complex mediated disorder will be a granular immunofluorescence. So what appears like that is, if this is the membrane, you are just going to see some dot kind of appearance. So this is not a form monomorphous appearance, right? So you have a dot kind of an appearance. That is what we refer it as granular immunofluorescence. So any immune complex mediated disease, you will see this kind of pattern only. And this pattern in PSGN has been referred to as the starry sky pattern. Under electron microscopy, if you see, these immune complexes are going to be deposited on the subepithelial location. So in this image, if you see, so these are the podocytes. So these cells are going to be the podocytes, and underneath this, you are seeing these large immune complex deposition. So they appear like humps, right? So under the podocytes they are present, so they are called as subepithelial humps. So this is a classical feature of PSGN. So any of this can come as image based questions also. They'll not just give you the image based questions, they'll give you some history as well. Just know about all these features, so you can immediately answer the question. Next, we'll move on to the second type of glomerulonephritis, that is the nephritic syndrome, which is rapidly progressive glomerulonephritis. Even though this RPGN presents with nephritic syndrome, it is basically a severe kind of disease. So any kind of glomerulonephritis in its end stage can progress on to RPGN. So it is just a severity based pattern. So any of the diseases can present with RPGN. So we have three basic types of RPGN, starting with type 1 and 1, 2 and 3. So first we'll be seeing about type 1. So type 1, here what happens is that there is going to be an antibody which is formed against the glomerular basement membrane. So basically the basement membrane. So this antibody is going to be directed against the type 4 collagen. So glomerular basement membrane is going to contain type 4 collagen. So any basement membrane will contain type 4 collagen. So against this type 4 collagens, alpha 3 chain and non-collagenous 1 domain. So NC1 domain of alpha 3 chain of type 4 collagen. So against this, antibodies are going to be developed. So these antibodies can also be directed against the basement membrane of the lung alveoli. So glomerular basement membrane and the lung alveolar basement membrane are going to be affected by these autoantibodies. So the best example of this is the Goodpasture syndrome. So Goodpasture syndrome, the patient will present with hematuria and hemoptysis. Out of this hemoptysis is going to be the earliest and the most common feature. Later on, the patient will present with hematuria. So since this is directed against the glomerular basement membranes, the antibodies, when they get stuck onto this glomerular basement membrane, they are going to give a linear appearance because membrane is going to appear linear. So this is an example of linear immunofluorescence. Let's see the image later. So next we'll see about the type 2 RPGN. So type 2 RPGN is going to be mediated because of immune complexes. So immune complex, any of the immune complex diseases can present with RPGN in their end stage. So the examples of these will be SLE, IgA nephropathy, Henoch-Schönlein purpura, even post-streptococcal glomerulonephritis and MPGN. So in glomerulonephritis, the examples are going to be very, very important. That is how you come to a diagnosis at last. So all of these examples can present with type 2 RPGN in their severe stage. And since these are immune complex diseases, they are going to have a granular immunofluorescence. Under type 3 RPGN, here there is going to be pauci-immunity. That is, there is not going to be any antibody or immune complexes like that of a type 1 or type 2, but here it is going to be ANCA associated, anti-neutrophil cytoplasmic antibodies. So already in blood vessels, we had discussed about the pauci-immune ANCA associated vasculitis, which was, yes, Wegener's granulomatosis, Churg-Strauss syndrome, and microscopic polyangiitis. All of this can again present with a kidney damage also, because it is a small vessel vasculitis. So kidney capillaries are also small vessels. So these can also be affected by these vasculitis, and they'll present with type 3 RPGN. And the classical example, since it is a pauci-immune, they will not have any deposits on immunofluorescence. That is very, very important. And one thing I need to stress here is both Goodpasture syndrome and Wegener's granulomatosis are going to have both pulmonary and renal involvement. So hematuria, hemoptysis is going to be present. So how do you differentiate between them? One thing is, in lung, if they mention cavity or nodule formation, then you think about a Wegener's granulomatosis. And in the question, they'll also give about a pauci-immunity or ANCA association with no deposits on immunofluorescence in the kidney for Wegener's granulomatosis. However, for a Goodpasture syndrome, you'll have this classical linear pattern of immunofluorescence. So that is how you identify, and also presence of this autoantibodies will be there in Goodpasture syndrome. So let's see the image-based questions related to RPGN. So already I mentioned grossly, RPGN can also present with this flea-bitten kidney appearance because of pinpoint hemorrhages. The light microscopic feature, this is the most important thing of RPGN. It is formation of these crescents. So this entire thing I am highlighting with the yellow color is going to be the crescent. Doesn't it look like a moon? Right? So that is why it is given this name crescent. So crescents are the classical feature which we see in RPGN. So these crescents are nothing but they are composed of this parietal epithelial cells. So parietal epithelial cells was the podocytes, right? So podocytes will be proliferating and they fill up the space between the parietal and visceral layers. That is the Bowman space. It is filling it up and forming this crescent. Along with this proliferation of parietal epithelial cells, we also have fibrin and this monocytes and macrophage, inflammatory cells like monophages and macrophages. So what actually happens in this, be it type 1, type 2 or type 3, eventually all of these diseases are going to cause a endothelial injury. So when endothelium is getting injured, what happens? There will be coagulation cascade activation and fibrin formation. So fibrin is formed and this fibrin will come out and it is going to be seen in between these crescents. So it will act like a gum to glue up all this parietal epithelial cells. So how do you remember the composition of this crescents? Remember it as flip. So F stands for fibrin, L stands for leukocytes, that is monocytes and macrophages, LI, immune cells also you can take, and P stands for parietal epithelial cells. So remember flip, you will not get confused. So students usually tend to get confused between parietal epithelial cell proliferation and visceral epithelial cell proliferation. So in crescents, we have parietal epithelial cell proliferation, while in collapsing kind of glomerular nephritis, that is collapsing FSGS seen in HIV associated nephropathy, there you are going to have a visceral epithelial cell proliferation. Okay. Under electron microscopy, RPGN will have a classical feature of a rupture of the basement membrane. So in here, if you see this black area, this darkened area, no? So this is the glomerular basement membrane. It is all continuous, but it is somewhat kinked and wrinkled, right? So along with that, here you see discontinuation, and here again you are going to see discontinuation. So both of this is called as a rupture of the basement membrane, which is classical of a RPGN. Okay. So immunofluorescence, I've already mentioned about the granular immunofluorescence, which can happen in type 2 RPGN. But this is the image of a linear immunofluorescence. If you see, it is looking like a ribbon, right? So entire glomerular basement membrane is being highlighted by the antibody, and that is what is called as a linear immunofluorescence or a ribbon-like immunofluorescence.